NOCC's Welcome to NOCC's November Ask the Experts. Today we have Dr. Esselen joining us, and we will be hearing from her. She is one of NOCC's funded researchers through some of our research funding initiatives. We have partnered with the Foundation for Women's Cancer to award 2 Young Investigator Research Awards, and Dr. Esselen is one of those awardees, and we're happy to have her with us today. She will be discussing her research in just a few minutes, focusing on quality of life research. So we're excited to hear about that. And we'll also talk a little bit about what a Young Investigator Research Award is, so that you can kind of get an idea of what her work entails. So we're glad that you're joining us today. Dr. Esselen is at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. And the title of her research is Evaluation of a Novel Financial Navigation Program to Alleviate Financial Toxicity for Women with Gynecological Cancers. It's a mouthful, but it sounds like it's very, very, very cool. I'm so excited to hear more about that, Dr. Esselen. So welcome today.
Thank you so much for having me. It's an honor to be here.
Thank you. Us too, us as well. So for those of you that are joining, you might be wondering, what exactly is a Young Investigator Research Award, and why is that so important, and why is that something that we've chosen to invest some of our research dollars into? Well, it's really, really critical, believe it or not. The Young Investigator Award it's usually a 1-year grant, which provides vital funding to promising investigators and researchers, such as Dr. Esselen, to really encourage and accelerate the quality of cancer research, and specifically for us in ovarian cancer research. So providing funding for these early career young investigators is much needed in those early stages in their careers in oncology research. And so these investigators really represent tomorrow's leaders for advancing cancer care. So we are very excited to acknowledge that and to be able to support those young investigators such as Dr. Esselen. So I'm going to turn it over to you now, Dr. Esselen. So before we hear a little bit about your research, what is maybe your connection to the ovarian cancer field, and why have you chosen that as an importance for yourself?
So thank you so much for the introduction, and I can't say enough thank yous for the support for this work. In terms of my connection to ovarian cancer, so I'm a gynecologic oncologist, and I have been in practice now 7 years. And one of the main diagnoses that I take care of is ovarian cancer. So I have the privilege of working with many, many women with ovarian cancer. And reflecting on sort of my career choices, I think back to the fact that ovarian cancer is probably the disease that drew me into this field in the first place. The complexity of the disease and its associated treatments, including the surgery, the chemo, and targeted therapeutics, were certainly very intellectually challenging and interesting and ever-changing, which is always exciting. But it was ultimately actually the patients that I had the privilege of caring for as a resident, and probably a medical student before that, that sort of inspired me, their resilience and grace in the face of a really challenging illness. Sort of inspired me to want to learn more and to train so that I could have the skills to care for women with ovarian cancer. And so certainly perhaps the motivating factor to my career choice, and the motivating factor now to getting up in the morning and continuing to do this work.
Love it. Love it. Yes, I love that. Thank you for sharing that. So what is your research looking at in terms of our research award, which is titled Quality of Life? What is your research looking at, and how is that important for women?
So my research isn't necessarily the typical sort of research that you would see in the field of ovarian cancer. It actually applies to a lot of cancers. What I'm looking at is investigating sort of something that has become a buzz term called financial toxicity. And financial toxicity is in specifically looking at how it affects women with ovarian cancer and other gynecologic cancers. So financial toxicity is what it sounds like. It doesn't have a strict definition, but it is essentially any significant financial distress or hardship that's associated with a cancer diagnosis and its treatments. And through some of our earlier work and that of colleagues, we've learned that about 50% of patients with gynecologic cancers, and really truly any cancer type, experience financial toxicity to some degree. And we learned that this is important. Obviously, it doesn't sound good to have financial toxicity, but this actually has a lot of implications for patients, their families, and for their health outcomes. And so in earlier work, we looked at financial toxicity through using validated measures to survey patients and learn more about sort of the degrees of financial toxicity and what that meant in terms of how they coped with their level of financial toxicity. And we learned that patients who do report some degree of financial toxicity are twice as likely to need to use their savings to pay for their treatment or care. They are 5 times as likely to reduce spending on sort of basic necessities, food, housing, et cetera, and 12 times as likely to need to borrow money or apply for financial assistance to pay for their care. Yeah. And when we look at financial toxicity and we compare it to quality of life scores, it is clear that there's a strong association between financial toxicity and worse quality of life. But what is even more worrisome to me as a provider and certainly to patients and their families is that we're learning that actually financial toxicity is actually associated with worse cancer outcomes, including in patients with ovarian cancer. In one of our studies, we learned that ovarian cancer patients with high financial toxicity or financial hardship were 7 times more likely to report delaying or avoiding their medical care as compared to those who don't have any financial toxicity. And in another study, we looked at medication compliance, which now has a lot of implications for patients with ovarian cancer who are on oral chemotherapies. And patients with severe financial toxicity were 4.6 times as likely to report not taking their medicines as recommended. Wow. So it comes as no surprise, I would say, knowing those sort of statistics, that there have been some broader all cancer type studies that have actually shown a worse mortality for patients with higher rates of toxicity. So I always say as providers, we're really accustomed to supporting our patients through major surgery, chemotherapy, all the adverse effects and complications of those different treatments, but we don't often measure or recognize the financial toll a disease takes on a patient or their family, which clearly has negative impact on their quality of life and potentially even worsens their cancer outcomes. So our research is striving to sort of find ways to address financial toxicity, to learn more about sort of the details of who's at risk and who and when the risk occurs and what sort of things drive financial toxicity. But we're also simultaneously trying to study an intervention to improve and mitigate the downstream effects of financial toxicity.
And what does that look like? Are you able to expound a little bit upon that at all for us? What that might look like?
Yeah. So to be specific about the project we're currently working on that you all have generously funded, we are kind of addressing both of those areas, looking to learn more about it in general. And we're doing that through patient-centered surveys, which we're really interested this time. In prior work, we'd kind of surveyed patients at all different points in their care, but now we want to understand from the beginning of the disease, how does this look? And so we're surveying patients as they enter care at their first visit, and then over the course of that first year of treatment at various time points, trying to understand, does it change over time? And it may look different for different patients, obviously. Does it matter what types of treatments, durations of treatments, complications, things like this? And how does this associate with the degree of financial toxicity? We're also measuring other things like changes in job status and employment, and really comprehensively trying to understand in a larger group of patients with ovarian cancer and also other gynecologic cancers, how the first year, how this occurs or what it looks like in the first year of diagnosis. At the same time, this funding and the award gave me that extra momentum to convince my department, we were already thinking about doing this, to really start our proposed financial navigation program. So we hired a financial navigator last spring who started working in June, who is an added layer of support for our patients to navigate exactly what it sounds like, the financial implications of their disease. So she went through sort of a series of training. Her background is being sort of a community needs resource specialist in a community practice. And she's now learning sort of navigate our bigger system, what all the resources we have available to patients, which aren't always obvious or easy to access. And she's sort of there to assess a patient's needs and help get them or their families to the resources that they might need. Most recent, yeah. And the last little bit of the study, or what we're looking at right now, we're actually instituting a screening program where we're actually screening all the new patients who come into our practice to find out if they sort of screen positive for having a risk of or already having financial toxicity. And they're now in a more streamlined fashion being connected with our financial navigator, as opposed to us just sort of discovering it through routine care.
Right. And is that, I assume that is what happens now, right? And so, gosh, I mean, the implications of this research to show if you could do screening on the front end to mitigate some of those outcomes in the end, I mean, that's just really, that's great. I mean, yeah, that's great.
Yeah. We're hopeful. I mean, it's a tricky thing because it's not a one size fits all problem. Right. For many of you, you're probably familiar with neuropathy, which is a complex medical problem that can happen from chemotherapy, numbness and tingling in your hands and your feet. And, we have different strategies to treat that, but sort of the root cause is very similar, whereas the cause of financial toxicity might be highly varied. And so it's hard to come up with a solution. So that's where our idea, and many others have similar programs or are trying to institute similar ideas across the country, to have a navigator who may not have all the solutions, but is going to know the system and know the resources that are available and be able to more effectively guide our patients through that. And then we also know from our prior research in our own center, and we're in Massachusetts, and we have nearly universal coverage for our patients, not totally, but we're pretty close to that as opposed to some other parts of the country. Yet we still have high rates of financial toxicity. And I can tell you as a provider, if 30 to 50% of my patients have financial toxicity, I maybe know about 10% of them. Oh, wow. So just through, the routine care. And so the idea of screening and identifying it, we're also looking at social determinants of health to help us find our patients' needs. So we're hopeful that we can report on this model by studying it rigorously as we're rolling it out and share that with other practices and communities, both in our local institutions and more broadly. Yeah.
So we can address it quicker on the front end and help mitigate some of those things so we have better outcomes for these patients. I love that. Right. I thank you for sharing all of that. It's very interesting and very, very important. So what about maybe this past year? What has that looked like for you in this research? Is there anything that you've noticed as far as key learnings, or what are you hopeful about? What does this past year look like, and where is it leading you to, do you believe?
Yeah, so it's hard work, and of course, nothing runs as you expect it to. I think that working within a large medical center, there have been some stumbling blocks in creating kind of clear and easy pathways for our financial navigator to access those services that do exist. Mm-hmm. But we're also in a time of great staffing shortages, I think, across all industries and so that's been a little bit of a struggle, but I'm so grateful to have our financial navigator as opposed to not having them in these trying times. I think that we are learning about what screening questions work well, how patients sort of feel comfortable responding to these questions or not. And as we sort of analyze the data and understand it better, I think we'll know more and we'll be able to define if this is a good way to assess this for patients. At the same time, we're also rolling out a social determinant screen, and maybe that's a better way to address these needs more efficiently. So we hope to understand that better soon. I am hopeful that, like you said, this is going to actually identify the problems earlier, and we're not certainly going to have all the solutions, but that our patients are going to feel better supported, and that there are patients out there who are in that group that were delaying and avoiding care or not taking their medicines as recommended, that are now going to be caught earlier than and have the resources to be able to adhere to the best practices and ultimately, hopefully, get a better outcome for their cancer care. So I am very hopeful about that.
That's great. That's awesome. So what are the next steps for you? So I know that, what are you almost halfway through your research now?
Yeah, I think it's going to be a lifetime of work.
A lifetime of work. Right.
But I do think for these projects, we are, nearly halfway to enrolling the patients in the sort of survey study part of it. I'm hopeful. We're working hard to figure out ways to enroll patients who are have limited English proficiency. That's something we've struggled with in prior studies and something we're trying to look at doing now. Again, like some of the limitations with staffing and changes in the way we use interpreter services in the post-COVID world, it's a little harder to do this. So we're seeking some ways to try to improve our enrollment of these patients. Our Navigator actually is bilingual in English and Spanish, so that is helpful. And so that's certainly high on my agenda to try to improve as we are still continuing the active recruitment of these patients. And then to begin to study our screening question, which we just rolled out last month. So we'll do sort of a look at our processes and see what we could make better and more efficient. And then ultimately, it's really a year's worth of sort of recruitment, but probably another year's worth of measuring and quantifying what we learned from this study.
Well, that's very, very exciting. Thank you so much for sharing about your research in this area of quality of life and how financial toxicity relates to that and relates to outcomes. We really appreciate that. We do have some questions coming in, so if you don't mind, if I might ask.
Of course.
Them now. So one of them, which is a really interesting question. So maybe what are some of the aspects of care for ovarian cancer that financially you've noticed demand the most from patients that you've noticed?
So I think it is a little bit dependent on what type of ovarian cancer and what the treatments are. So obviously there's a wide variety. I think up front, a lot of people do have surgery as part of their primary treatment. And I think surgery, interestingly, what I'm learning a little bit from our work, and I hope to understand better after this year's work, is the time off work and whether people who are actively working when they're diagnosed and the different kind of employment benefits and types of insurances and how that can play a big role in lost income and just, needing to be on disability. That actually, I think, is not well understood. And I think that has policy implications if we can show that people who have to take a certain amount of unpaid time off, and sometimes ovarian cancer surgery is a big recovery with, a long recovery and people aren't able to get back to work. Maybe there's a way to improve that, sort of those who are losing, important wages and having to make difficult decisions about their jobs. I think the big one that a lot of people worry about in more advanced disease, and certainly in maintenance therapies now, or potentially in recurrence, are some of the oral chemotherapies that we're using, the PARP inhibitors. In some of our research and in national research, it's actually been shown that the out-of-pocket costs for those can range widely. And so for some patients, it's not a big burden, it's well covered. And for other patients, it is a massive burden. And so I think that that's an area where clear out-of-pocket costs are really potentially quite dangerous. And you can be on those medicines for many months to years. So that's certainly an area of concern. And we're looking at that as well. And then generally insurance and high deductibles. I think in our earlier work, we didn't do a great job of understanding what patients' out-of-pocket costs were for, what they paid just to have insurance. And a lot of our ovarian cancer patients are younger than Medicare eligible. And those are patients with high deductible plans and high premiums that they're paying. And so we're trying to get a better understanding of how that affects or how that plays into the financial toxicity. But it is interesting when we look at our prior work, the one driver of always associated with higher toxicity is chemotherapy. And this is looking across all cancer types. So most women with ovarian cancer get chemotherapy. So by definition, almost women with ovarian cancer who get chemotherapy are higher risk for toxicity.
Financial toxicity, yeah.
Yes, financial toxicity and other toxicities.
Yeah, right. But financial, yeah.
Yes,
sure.
yes.
Okay, very interesting, very interesting. Another question that came through is, the research that you're doing, is it intended to be replicated across the country in various hospitals and clinics? So I think you may have spoken to that a little bit.
Yeah. I mean, ideally, yes.
Ideally.
If it's successful, I think we're going to learn a lot. And by, this is sort of a clinic-based initiative, although it does carry over into the inpatient setting, our Navigator, that is. I think we're going to learn a lot of lessons, and the funding is allowing us to really study it more rigorously, helping protect some of my time and fund a research assistant so we can really measure everything and learn what works and doesn't work. And so my hope is that, I don't anticipate our program is perfect from the get-go. We've already made a few changes, and that we, at the end of the day, will be able to report on really what broadly the needs of ovarian cancer patients are, and what are some effective interventions, and does screening and use of a navigation or a navigator, does that actually help?
Does that make a difference? Yeah.
And if so, we can do a how-to on implementation.
That's right. That's absolutely right. And for those that are, there was a question that came through regarding this, and I was wondering the same thing. Is there, you talk about this wonderful financial navigator. Is that someone who is normally a part of like an oncologist staff, or how does one make sure that they are able to get access to a financial navigator?
That is a great question. And I think it varies very much based on where you are in practice. I have some colleagues across the country also trying to do similar endeavors. And generally there is somebody affiliated with the practice who is available to answer financial counseling questions and insurance questions. But it's more complex when you're a cancer patient. It might involve talking to a chemo pharmacist. It might involve, more than just sort of routine questions about your bills. And so that's the idea behind a navigator. And I think that's what a lot of a financial navigator, a lot of programs don't necessarily have somebody who comprehensively kind of cares for patients with certain or all cancer diagnoses, and has the network within the local institution to kind of refer and seek assistance from a variety of different types of people with different expertise, in addition to potentially providing support for things like parking and transportation and even, housing, food insecurity, and these other sorts of social needs that all play into having financial toxicity. And so the idea of our navigator is that they have a closer link to the care team and are available to look at the sort of big picture and not sort of, the pharmacy costs versus the insurance problems. And so what I would say is in our institution prior to this, a lot of this fell to sort of social work or community needs resource specialists. And so the care team would identify it, and a social worker would come in and try to fit this, sort of role, and may even do that in other institutions with that title as a financial navigator. And so I would seek out sort of the social services support if you're having trouble and there isn't a actual named financial navigator, because there likely are resources.
Yeah. Thank you for that. Yeah. And that's why, this whole issue of financial toxicity is so important to address. And that's why we are able to, as an organization as well, offer a newly formed financial assistance program. So I just wanted to give that a little plug here at the end, that if you're in need of financial assistance for treatment or clinical trial participation, we do have a NOCC financial assistance program that you can find information on ovarian.org, which is just one step to, helping you navigate your care. So let us know if you need help with that. But well, we really appreciate the research that you're doing, Dr. Esselen. It's very exciting. It's very needed, very, very needed. We're just so thankful for your research, and we wish you the best in continuing that. And hopefully one day we can have a much better program for all patients that come through in these situations. So thank you for your research and thank you for doing what you do.
Oh, it's my pleasure. I always said I wish I could be the one to develop the early, the cure or the early detection. But, when you see and you're caring for women with ovarian cancer who are struggling with these things that they shouldn't have to have as part of their care, and then to see it actually affecting their outcomes. This is definitely something I feel like I can put a dent in, and when I'm not doing the actual work of the cancer care where we direct our efforts. So I'm so appreciative for your support. Absolutely. And for all of our patients who are participating in our work. It's super important to hopefully helping everyone.
Absolutely. Well, thank you for joining us today, and we will see you all next time.
Thank you.